gentlemen, our next speaker is currently serving as a consultant rheumatologist at Fort Worth, Texas. He is an alumnus of Dow Medical College, and he went on to complete his medicine residency training at St. Elizabeth's Medical Center in Boston.
He has led multiple phase 3 and 4 trials as principal investigator to test the safety and efficacy of drugs. Ladies and gentlemen, please welcome Dr. Syed Raza Jafry to the stage.
I will be talking about what is new in Anca-associated vasculitis. Although Anca-associated vasculitis includes all these disorders, but I am going to talk about the first two disorders today. We will start with a clinical case. A 67 years old female is referred to you for the new diagnosis of GPA with active disease involving sinus, joints, and asymptomatic lung disease, which is represented by 2 pulmonary nodules. There is no active renal involvement. Which of the following medication will be least preferred option for this patient? By the way, I will also like to announce that there is a handsome prize for the winner of the quiz at the end of the discussion, and this quiz is also associated with negative marking. So the loser may be एक ज़ेर अताब पठान खान की हिमायत में उसे हो सकता है धर लिया जाए. Any thoughts about which would be the least preferred option over here? So whenever you are going to see a patient with Anca-associated vasculitis, the first question that you need to answer is whether the patient has severe disease or non-severe disease. The severe disease is represented by pulmonary hemorrhage, active glomerulonephritis, CNS involvement, mononeuritis multiplex, cardiac involvement, GI bleeding due to vasculitis, while non-severe disease is going to be represented by sinonasal disease, oral mucosa involvement, skin involvement, joint involvement, and lung involvement can be there, but generally it is without any respiratory compromise. So based on this classification, our patient belongs to which group? Severe or non-severe? Non-severe. Since the first patient with GPA was reported sometime in late 1890s, corticosteroids have been the mainstay of the therapy for a long period of time. However, this monotherapy was associated with high mortality and long list of side effects. This was followed by the introduction of two-phase approach, which is induction and maintenance phase. This was based on observational clinical trials which showed that using cyclophosphamide in combination with glucocorticoids is associated with improvement in the survival as well as there was lower relapse rate. This combination was associated with remission in about 70 to 90% of the patient. This was followed by introduction of other agents which has basically changed the outlook of the disease. So in 2023, for non-severe disease, the induction therapy options include methotrexate, rituximab, and mycophenolate. Just remember that glucocorticoids are the standard part of any therapy for induction phase. So do we have any proof for this? This study, NORAM trial, compared cyclophosphamide with methotrexate in non-severe Anca-associated vasculitis. These patients mainly were having involvement of upper respiratory tract. There was no significant renal disease. The results were that 90% of the patient in methotrexate group were able to achieve remission versus 93% patient in cyclophosphamide group. So the conclusion was that methotrexate is not inferior to cyclophosphamide as induction therapy in non-severe disease. This is another trial where IV cyclophosphamide was compared with oral mycophenolate for induction therapy. 140 new patients were included in this trial. The remission was achieved in 67% of the patient with mycophenolate and 61% patient with cyclophosphamide. However, if you notice over here, the relapse rate was much higher in mycophenolate versus cyclophosphamide. So the conclusion were that mycophenolate is not inferior to cyclophosphamide for induction therapy, but can be associated with high relapse rate. So the correct answer over here is that the least preferred option is going to be cyclophosphamide because it is effective, but it is associated with high risks versus benefits. Rituximab and methotrexate are reasonable options for induction therapy. Mycophenolate can also be used for induction, but just remember, because of the high relapse rate, you should try to use them in patients who are at a low risk of having relapse. Going to our second patient, you are asked to see a hospitalized 52 years old male with a new diagnosis of GPA involving sinus, skin, kidney, creatinine is 2, active urinary sediment, pulmonary involvement. In addition to steroids and avacopan, which of the following would be the first choice of the treatment? Any thoughts here? So in 2023, what are the options for induction therapy for the severe disease? So now I think all of you agree that the second patient had severe disease. The options include cyclophosphamide or rituximab in addition to avacopan. And again, as I said earlier, steroids are going to be the standard part of any therapy. RAVE trial looked into the comparison of oral cyclophosphamide versus IV rituximab along with the steroids. 197 patients were included in this trial. In rituximab group, 64% patients were able to achieve remission versus 53% in cyclophosphamide group. And if you start looking at the subgroup of the relapsing patient, because in this study, newly diagnosed patient as well as the relapsing cases were included. In relapsing patients, rituximab was able to achieve remission in 67%, while cyclophosphamide group was able to achieve remission in 42%. So what were the conclusion? That rituximab is at least as effective as cyclophosphamide for induction therapy. And this was basically the basis of approval of rituximab for induction therapy in severe Anca-associated vasculitis. This is another trial. In this trial, IV cyclophosphamide was compared with rituximab infusions. In this, 44 patients were included in the trial. The hypothesis was that rituximab is better than cyclophosphamide. The results were that in 76% patients in the rituximab group were able to achieve remission versus 82% of the patient in cyclophosphamide group. So the conclusion was that rituximab was not superior to cyclophosphamide, but was at least as effective as cyclophosphamide. What about the combination of using cyclophosphamide and rituximab? That was one of the options in the questions. So the current data does not support the use of the combination therapy. The reasons are this is a very controversial issue. There are publications, there is data supporting the use of this combination, and this is based on the rationale that it may lower the exposure to chronic steroid therapy. But there are issues with the data, so at this point that is not recommended. So then the questions comes, which agent, rituximab versus cyclophosphamide in severe disease? So in settings in which you should prefer rituximab are relapsing disease, newly diagnosed patients who are at extremes of age, like young patients or old patients because of fertility issues and poor intolerance in elderly population, patients who have cytopenias, patients who have history of any malignancy. Settings in which cyclophosphamide can be preferred are the patients who are unable to tolerate rituximab, have been having worsening of the disease despite using rituximab, and in a subgroup of patients who are having severe renal disease or severe pulmonary hemorrhage. So as you folks pointed out, rituximab was the right answer over here. Why? Because methotrexate and mycophenolate are the options for non-severe disease, not severe disease. Cyclophosphamide would have been a reasonable option, but rituximab seems to be a better option. And as I said, this is not supported by the current data to use the combination. Now, what about the maintenance therapy? So in this trial, cyclophosphamide was compared with azathioprine for maintenance of remission. So after achieving induction with cyclophosphamide, the patients who went into remission were divided into two groups, either cyclophosphamide followed by azathioprine or azathioprine alone. What were the results? The relapse rate at 18 months in cyclophosphamide was about 13% versus in azathioprine group it was about 15%. By the way, ये किस्मत की बात है, जवानी में कभी लड़कियों की तरफ से कोई पैगाम मैसेज नहीं आया. अब जब बुढ़ापा शुरू हुआ है तो पर्चियाँ आनी शुरू हुई हैं. तो इसको पढ़े बगैर I'll take it as a compliment. So what are the conclusion? Azathioprine maintained remission without increase in relapse rate, and the adverse events were quite similar. In this trial, methotrexate was compared with azathioprine for same thing, maintenance. Methotrexate versus azathioprine. The results were at 29 months. Relapse was seen in 36% of patients with methotrexate group and 33% of patients in azathioprine group. So conclusion were that azathioprine and methotrexate are comparable agent for using as maintenance therapy. In this trial, mycophenolate was compared with azathioprine for remission. After achieving, giving induction therapy with cyclophosphamide and achieving remission, the patients were divided into two groups, azathioprine versus mycophenolate. The conclusion were that the relapse rate was 55% in mycophenolate group and 38% in azathioprine group. So the conclusion was that mycophenolate was less effective than azathioprine for maintaining remission. In this trial, rituximab was compared with azathioprine for maintenance. So cyclophosphamide was used for induction therapy, and then the patients were divided into two groups, rituximab infusion versus oral azathioprine. The results were that the relapse was seen in 5% of the patients with the rituximab group versus 29% of patients with azathioprine group. There have been several queries about this study because a lower dose of azathioprine was used, but no one knows what would have been the results if we were using azathioprine at 2 milligram per kilogram. So the conclusion was that rituximab was more effective than azathioprine for maintenance therapy. Now in this trial, as compared to the previous trial, rituximab was used for induction as well as maintenance. So maintenance was compared in two arms, rituximab infusion versus azathioprine. So at 24 months, over here, the relapse rate was seen in 13% of rituximab group versus 38% in azathioprine. So what are the conclusions? That rituximab is more effective than azathioprine for maintenance therapy. Then the question comes, what dose and how often should we use rituximab? So again, there is no standard protocol over here. Most of the rheumatologists are using 500 milligram every 6 months for maintenance. Some are using it every 4 months. Some are using on-demand strategy depending upon the B lymphocyte reconstitution as well as the Anca titers. There are several questions. What are going to be the toxicity with using rituximab for a long period of time? Those questions needs to be answered in future trials. Do we still have role for conventional therapy like azathioprine, methotrexate, mycophenolate? Yes, we do. It depends upon the case, prior history of toxicity, comorbid conditions, hepatitis B, pregnancy status. When should you start maintenance therapy with rituximab? If it is used as induction, you should start maintenance therapy 4 to 6 months after the last infusion with rituximab. If IV cyclophosphamide was used as induction, then maintenance therapy can be started 2 to 4 weeks after last infusion of cyclophosphamide, as long as the white cell count and ANC is within reasonable limit. If you have used oral cyclophosphamide as induction, then maintenance therapy can be started even earlier. What is the role of plasma exchange? So in this trial, all the patients were treated with the standard therapy, cyclophosphamide versus rituximab with steroids. But the patients were divided into two groups, plasma exchange and no plasma exchange. What were the conclusion? The endpoint in this study was end-stage renal disease or death. Plasma exchange did not reduce the risk of end-stage renal disease or death in this particular trial. So is there still any role of plasma exchange? Yes, we do. If a patient has both Anca-associated vasculitis and also has evidence of anti-GBM disease, then plasma exchange can be considered in addition to the conventional therapy. If patient has severe kidney disease like creatinine above 4 or they are needing dialysis, then you can consider plasma exchange, and patients who are having severe pulmonary hemorrhage. Let us move to our last case. Which of the following is an indication to use avacopan in GPA? Any thoughts? So let us look at the data. So avacopan, as you know, it's an oral small molecule inhibitor of the complement 5A receptor. In this trial, which was reported in New England Journal of Medicine in 2021, avacopan was compared with placebo. In addition, so just remember, cyclophosphamide or rituximab is the standard therapy in addition to steroids. So those were given in both arms. In this, avacopan was compared with rapid taper of steroids. The conclusion were that at 52 weeks, in avacopan group, 66% of the patients were able to achieve remission versus 55% patient in steroid group, traditional steroid group. So the conclusion was that avacopan was not inferior to prednisone in inducing remission at week 26. As you see, the results were comparable, but it was superior at week 52. So where do we stand about avacopan? It can be used in addition to cyclophosphamide or rituximab in patients who have active severe disease, whether it's newly diagnosed or relapsing. Try to start it as early as possible and try to taper down the steroid as soon as possible. Try to avoid this drug in patients who are having uncontrolled liver disease or are on certain medications. Always remember non-medical management like humidification, moisturization for nasal care, as well as intratracheal dilatation injection for patients who are having subglottic stenosis, because conventional immunosuppressive therapy is not effective in this situation. What are the conclusions? GPA today is a treatable disease. First, determine whether patient has severe or non-severe disease. Severe disease, use rituximab or cyclophosphamide with steroids. Consider adding avacopan. For non-severe disease, use methotrexate, mycophenolate, or rituximab. And then patients will need a maintenance therapy. Rituximab seems to be the best option, although the conventional agents still have the role. And remember to use non-medical options also. Thank you very much.
Thank you, Dr. Jafry. It has been a privilege having you with us today.